Hey, podcast listeners, Fawaz Al-Mufti here from Westchester Medical Center, New York Medical College, and this is the Neurocritical Care Society podcast. Clinically unresponsive patients can have EEG or MRI evidence of brain activation in response to spoken commands. Some reports describe approximately 14% of chronically unresponsive patients may have a dissociation between behavior and brain activation, a phenomenon referred to as cognitive motor dissociation months or even years after the injury. However, the prevalence and prognostic relevance of this dissociation, if detected in the days soon after brain injury, are not well understood. There has long been an interest in the ability to identify who harbors this potential for recovery shortly after brain injury, as this may carry huge implications on decisions regarding withdrawal of life-sustaining therapies. I am extremely pleased to be joined today by Jan Claassen, who is an associate professor of neurology and neurosurgery, as well as the head of neurocritical care and the medical director of the neurointensive care unit at Columbia University Medical Center. Dr. Claassen is a renowned expert in the management of acute neurologic emergencies who has championed the use of cutting-edge brain monitoring techniques throughout his career. Having trained with Jan at Columbia, I consider myself a disciple of the same school of thought. Today we'll be discussing the findings of his paper entitled Detection of Brain Activation in Unresponsive Patients with Acute Brain Injury that was published in the New England Journal of Medicine last July 2019. Listeners, please excuse my anxiety attempting to interview a guy who can read your thoughts before you can. Jan, congratulations on your publication and welcome to the NCS podcast.
Thank you, Fawaz. It's really an honor to be interviewed by you, and it's a great pleasure and opportunity for me to share the findings that we had in this study, which I'm very excited about.
Absolutely, very exciting findings. All right, so let's dive right in. So could you tell us something about the background research and prior work that was done on cognitive motor dissociation, and what did you actually seek to achieve?
So Fawaz, some of this you already summarized really elegantly. To sort of put it a bit in context, patients with acute disorders of consciousness are very commonly encountered in the critical care setting, not just in the neuro-ICU, but in critical care units throughout the country and throughout the world. What's very sort of thought-provoking and interesting is that withdrawal of life support therapies is the most common mode of death in brain-injured unconscious patients. What's striking about this is that we are very, very bad at prognosticating who will recover and who will not recover. My goal with this work was to see whether we could get more accurate assessment of consciousness that would support our recovery prognostication. If you talk to families and listen to goals of care discussions, the current state of consciousness and the predicted recovery of consciousness features heavily in decision making. A number of different approaches, including behavioral assessments, imaging, and electrophysiological techniques, have been proposed and have been used. I chose to build on the great work started by Adrian Owen more than a decade ago, which group had shown that some patients that appear unresponsive have activation patterns in the brain that are similar to healthy volunteers. So he was presenting these patients with commands and looking on function MRI and found similar activation patterns. I chose to apply a paradigm using EEG, as this is performed at the bedside and can be repeated many times.
Excellent. So what can you tell us about the trial design, methodology, and your primary and secondary outcomes? And what was the effect size you were looking for? I'd also appreciate if you can expand maybe on the machine learning process and the steps you've taken for validation.
Primarily wanted to see if we could find patients that had brain activation to commands without any behavioral expression of this command following, or to see whether we could detect that in a significant number of patients in the acute setting early after brain injury. And we used single-use headphones that you throw away after use so that you don't transmit infections from one patient to another. We played these standard commands asking the patient to open and close their left hand, and then open and close your right hand, and went back and forth and asked them to stop opening and closing your right hand, stop opening and closing your left hand. And we used regular EEG electrodes, nothing fancy, the same setup that we use for routine monitoring in the ICU, same montage, not more electrodes, the same setup. So very sort of routine setup. We presented the commands repeatedly and went always in what we on the left side, did it again on the right side, and generated this data set by doing that in each patient. EEG data was then analyzed using power spectral density analysis, which basically takes the frequencies, different frequencies in the EEG, and looks at power in these frequency spectra. And that generates EEG features for each electrode, sort of locked to the commands. We then used a support vector machine learning algorithm, that's the algorithm that you were referring to classify the data, comparing and opening and closing commands to rest commands. And what it does is basically looks at the EEG, it looks at whether there are systematic changes with the movement compared to the stop moving command. This generates then, by using statistical processing and analysis, generates a UC area under the curve that identifies patients that systematically are able to distinguish move from rest commands. We have to be sure that the findings are not by chance. We did a false discovery rate correction, and classifier reliability was tested with permutation testing, where we basically randomly shuffled the labels of whether the test that the clip was a move command or a stop moving command. And that basically allowed us to identify these patients that had cognitive motor dissociation, as you explained before, a state where you're able to have better cognitive function, the ability to distinguish between different commands, but you have no way of expressing that with motor commands.
Wow, that's excellent. All right, can we elaborate on the findings of the trial?
So when we started this almost half a decade ago, we didn't know whether we would be able to identify any patients. And it was quite questionable because there's a lot of confounders. We have sedation, we have metabolic derangement, patients are acutely brain injured. So we weren't sure that that was possible. But we were able to show that 15% of the patients that showed no motor response at all to commands had this state of cognitive motor dissociation. These sort of followed the same classification performance as healthy volunteers. They didn't have as high performance, but they followed the same classification. And unlike the 85% that did not have the cognitive motor dissociation, we found this in patients with different acute brain injuries. It was most commonly seen in subarachnoid hemorrhage, TBI, and ICH patients, and least frequently seen in cardiac arrest patients. There were no clinical differences. We looked for other things that could distinguish these patients. We couldn't find any other behavioral findings that could identify the CMD from the non-CMD patients. And we were able to find this in different levels of sedation as well. So in patients that are completely sedated, deeply sedated with pentobarbital, we did not include because those probably wouldn't have this. But with some mild to moderate sedation, some patients were able to have the cognitive motor dissociation as well. Most interestingly, patients that had cognitive motor dissociation more frequently also started to follow clinically to the commands before hospital discharge. This occurred on average 6 days after the CMD was diagnosed. And on 12 months follow-up, so a year after the injury, patients that had CMD compared to the ones that didn't have CMD, even though they looked at the assessment exactly the same, had a much better functional outcome on a relatively crude functional outcome scale, the Glasgow outcome scale extended.
Wow, that's fascinating. So of the patients who did not have cognitive motor dissociation, approximately 14-15% of these patients still had motor recovery. And 26% of the non-cognitive motor dissociation patients were also able to follow commands at discharge, at 12 days though, rather than 6 days. The question is, how do we improve the specificity of cognitive motor dissociation as a predictor of consciousness recovery? And is cognitive motor dissociation specific to the temporal course of recovery? Or is it perhaps specific to a subset of neuroanatomical causes of delayed absent command following?
These are really, really good questions and really important to address. In my interpretation of this test, our EEG enhanced assessment is just like any other behavioral assessment. So let me give you an example. If you go to the bedside and you ask a patient to follow commands, and they are conscious, but they decide not to follow commands, they decide not to do it, you would not be surprised if some of those patients would still recover. It's the same thing with our EEG enhanced command following assessment. If the patient willfully, for example, decides not to participate, That doesn't mean they're not conscious. That doesn't mean they cannot recover. But we are able to identify some patients that cannot behaviorally follow commands, that with their brain activation actually do systematically have activation to the commands. I would also caution to say that this is an assessment of consciousness because we don't really know what consciousness is. This is just activation pattern that we systematically see to one command compared to another command. In order to improve the accuracy, I think there's a number of things that we need to do. I think first of all we need to know what is the mechanism underlying cognitive motor dissociation. We don't know that at all. Why are some people not able to express this, even though they actually have the brain activation? Initially, one of my thoughts was, is this sort of an extreme case of abulia, where the patient just does not want to interact? I don't know whether that's true, but I looked at a large number of the MRIs in these patients. We were lucky enough to have a pretty large cohort of these patients that had MRI scans done. And if you look at classic MRI injuries associated with abulia, there were only 4 of the patients had that. Doesn't mean it's not an extension of that phenomenon, but it's probably not all. We're trying to get a better handle at sort of what is underlying this and what is the neuroanatomical correlate. By now, we had a mixed cohort of patients that we studied, by now focusing on one cohort. So we're lucky enough to receive some federal funding to do a multi-center trial in patients with intracerebral hemorrhage and study basically how many of those patients have cognitive motor dissociation, what's their outcome. And so in these patients, we're going to be able, ICH I chose because it's a focal injury combined with some diffuse injury. I think it will allow us, hopefully, to get some insight into what are sort of the injuries that are associated with the phenomenon of cognitive motor dissociation.
Absolutely. Wow. Congratulations on getting the funding. That's terrific news. So I just wanted to circle back a little bit about the machine learning portion of the paper and something that you just mentioned about the EEG reactivity. Do we know the concordance between EEG reactivity and this method?
So this is, we don't really know. Some of these patients had EEG reactivity, but what you have to understand is that these patients don't just have EEG reactivity, but they're able to distinguish between one command from another command. So it's not that they just responded and there's some activation to a command, but they had a different response to one command when compared to another command. So I think this is quite different. This goes way beyond reactivity, and reactivity alone is not very standardized at this point in time. There's some great work being conducted at several centers trying to sort of standardize the responsive, the EEG response a bit better. And I think that might be actually also a good approach to sort of aid our prognostication. But it would not get at whether patients have cognitive motor dissociation. There may be an overlap, and I think this is a good way to think about it because potentially this could be done cheaper and easier. But I think it's not going to be the full answer.
Completely understood. Early on, we spoke about how one of the major strengths of this paper is the fact that we are able to perform this at bedside. In your opinion, what are some of the barriers to bedside implementation of an approach like this? And what are the moral and ethical implications of this work in the acute setting, in contrast to chronic disorders of consciousness population?
I think these are crucial questions that you're asking. There are some practical obstacles, and then there's bigger ethical background obstacles. Let me start with the practical one. So you need to have a setup that includes a computational analysis approach. Some of this analysis is computationally quite heavy, and you have to have a way to synchronize the verbal command presentation exactly with the EEG. And there's some sort of ways that you have to do that by feeding back from a computer that gives you the verbal command into the EEG signal. We published actually with the paper on the experimental setup that we used. And we also published all of the code that we use to analyze our data. One of my goals is to make this as widely applicable and as widely sort of used as possible, because I think it doesn't help actually if we can just do this in some very sort of high-tech centers. And this raises major ethical problems as well, or questions. The biggest ethical problem we started with, I think the biggest ethical problem that at this point in time, many patients have care withdrawn based on very insufficient data and very inaccurate data. We are not good at prognosticating the future and recovery potential of patients. And so this is, I think, the biggest ethical problem that's not generated by this kind of work, but it exists at this point in time. It has existed for many years. I think together with when we start work like this, we have to have a societal debate that accompanies this research, and there are questions of equity and that have and societal burden that may be associated with generating sort of programs that are able to work on this that may be raised. So I think those are important discussions that we as a society of physicians that take care for these patients have to sort of face and have to address.
Excellent. Thank you so much for clarifying. There are many strengths of the paper. Can we discuss those and also the limitations of the trial?
I think we talked about some of the strengths. I think some of the strengths are that this finding that we have for the first time in an acute setting was linked to a long-term outcome, something that is typically perceived as important for patients. So I think that's one of the strengths. I think one of the strengths as well is that we were able to show this in different etiologies. So this is a phenomenon, just like the clinical exam is a phenomenon that is not specific to one disease, not specific to TBI or specific to one specific condition. However, there are a number of limitations. This was a relatively small study. It was a single-center study. We were not powered to show differences between the underlying etiologies, and therefore were limited in sort of gaining insight into the mechanisms underlying this phenomenon. We need to have much larger studies that are multi-center, that first of all replicate these findings, and then also allow us to more in detail see, is this something that is occurring at a similar frequencies in different etiologies, or more specific to kind of injury patterns. So we saw at least frequently in patients with cardiac arrest, and this may be just because we were underpowered to show differences between etiologies, but it's also conceivable that patients that have a very diffuse injury pattern are not able to have cognitive motor dissociation at the same rate as other patients. We don't know that at this point in time. That's a big limitation. We also need larger scale studies that don't just obtain crude functional outcome scales, but that look at quality of life, cognitive outcomes. What does it mean to families when these patients survive and become part of their family again? So I think those studies, some of which are in the works, and some of this which are just sort of thought about and need to be started, are crucial if we want to at some point hopefully offer this to many, many patients throughout the world. At this point, I would just ask for caution not to jump to too many conclusions and think that we have lead tests to predict outcome in all of the patients with acute brain injury that are in unconscious state within a couple of days of the brain injury.
Terrific. With artificial intelligence rapidly evolving, when do you expect such Black Mirror technology to actually approach real time? And what does the future hold for machine learning and critical care EEG? And what does this mean for the majority of us lacking such machine learning technologies within the multiple modalities of neurocritical care?
Those are really excellent questions. I like the Black Mirror. There's an enormous potential beyond coma assessment and prediction of artificial intelligence and machine learning approaches. This is just one field where we're applying this, and I think we have a wealth of data that we utilize only to a minimal degree in the critical care setting. There's amazing work being conducted by others in detection and prediction of complications in critical care in general. So this is going to be these are going to be approaches that are going to revolutionize critical care and medicine in general, far beyond the assessment of coma and prediction of recovery. But specifically regarding coma, my hope is that we're going to be able to integrate this in more accurate prediction algorithms, that we are working on a project where we're trying to see whether some of those patients that have cognitive motor dissociation, so they have some way of willfully modulating their brain activity, whether we can use this technology to reconnect. So, and this is called brain-computer interface, where we're trying to train patients to sort of steer a computer, even though body parts. And so that's one additional sort of, I would say maybe Black Mirror kind of application of this technology, hopefully in the future. Is this definitely going to be possible? We don't know at this point in time. But the work is sort of accelerating at a mind-blowing speed. So this hopefully will help in the future. This cannot be done just by one group or by two or three groups. And so I'm very, very pleased to have seen that the Neurocritical Care Society has come together to start the Curing Coma campaign. This was launched last week in Vancouver at the Neurocritical Care meeting. And in my mind, in my opinion, this is the most ambitious initiative by neurocritical care and scientists interested in the study of consciousness to date. The idea is to bring scientists from all areas of critical care, of neuroscience, of every walk in life, including patient advocates, and also, last but not least, neurointensivists, including nurses, pharmacists, every kind of healthcare worker that's encountering these patients, to work together and trying to push this forward so that hopefully we can cure coma in the near future.
Excellent. Jan, it's been an absolute pleasure speaking with you about this. In conclusion, I'd like to congratulate you, your co-investigators, the patients and their families for their incredible efforts in providing us with this critical insight towards better understanding coma and curing coma, hopefully, one day. I would like to finally also thank some of my colleagues for helping me prepare this podcast, Nahid Ngaich, Christopher Zammit, Brandon Foreman. Thank you all for listening, and I hope you enjoyed this episode. The NCS podcast series is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, and advocacy in neurocritical care. Our production staff includes Fawaz Al-Mufti, Ramani Baloo, Mike Brogan, Josh Levine, Benjamin Miller, Sterain Shepard, Jim Siegler, Sarah Stern-Nezer, and Chris Zammit. Our senior producer is Bonnie Rousseau. Our administrative staff includes Bonnie Rousseau and Angel Gindel. Music is created by Mohan Kadapali from the Division of Neurocritical Care at the University of Miami. The NCS podcast series is available on NCS On Demand and wherever you may listen to your podcast. For more information, please follow us on Twitter @Neurocritical or on Facebook. I'm Fawaz Al-Mufti, and thanks for listening.